This is a very exciting study, and we were actually quite remarked at the outcome. The results were just published in the New England Journal and released today at the ASH meeting in 2015. What the study basically was asking the question if patients over age 65 who may not be amenable for more aggressive chemoimmunotherapy regimens, whether they can be then given treatment with either a drug called Chlorambucil versus a drug which is now currently being investigated, Ibrutinib, in a frontline setting. Ibrutinib is a new type of drug. It's a drug that inhibits an enzyme in the cell, Bruton's tyrosine kinase, or BTK. And this acts in a mechanism different than your standard chemotherapy, such as represented by Chlorambucil. This drug actually inhibits signaling to the B cell, and it also causes the B cells to flush out of the lymph nodes and the marrow. So patients typically experience an increase in lymphocyte counts during the early stages of treatment, but of dramatic reductions in the lymph nodes. And over time, the lymphocyte count may come down. This drug has actually shown to be effective in treatment, and for that reason was approved for treatment of patients who had relapsed disease as a single agent drug given once daily. It's an oral drug, so that makes its administration somewhat convenient. The drug has been approved for patients with relapsed disease, with the exception of patients who have leukemia cells where there's deletion in 17p. And patients with this type of genetic change typically respond poorly to chemotherapy regimens. And I personally would not recommend giving chemotherapy, a standard chemotherapy treatment, to such patients, because what we risk is that the patient may not respond well, but they may be experiencing toxicity such as suppression of their marrow, resulting in more anemia and thrombocytopenia. And that's a difficult clinical situation to be in. So this drug was now being considered, well, what if we compare it with a drug that would ordinarily potentially be used in a frontline setting, such as Chlorambucil? So the study design was to have patients over age 65, and we purposely excluded patients who have leukemia cells that have this deletion in 17, chromosome 17, for the reasons that I just stated. It would not be really rational to give Chlorambucil to such patients. So this was actually very important in the study design. The patients then were enrolled in the study, and then they were randomized to receive either the drug Chlorambucil or the drug Ibrutinib. And the randomization process worked. The patients were fairly easily, similarly stacked. We didn't see a lot of discrepancies between age or risk factors that we typically associated with poor outcome over the long term. So that made it very important to try and compare the outcome of these two treatment regimens. Well, it's fair to say that we observed that patients who were given Chlorambucil over the period of time did have responses. We did not see any complete remissions, but they responded as well as might be expected. In fact, the response rates to the Chlorambucil treatment arm was actually better than some published studies with Chlorambucil. I think potentially because we had deleted a small subset of patients that might have poor outcome with Chlorambucil. But the progression-free survival of patients who are continuing to maintain themselves on Ibrutinib was significantly longer. Now, what was very surprising about this study is that when we did the analysis, we found that actually there was a slight but significant survival advantage for those patients who were randomized to receive Ibrutinib. Now, this seems a bit confusing because patients were given the opportunity to cross over. If they were taking one arm and had problems with it, they could cross over to the other arm. So patients receiving Chlorambucil could go and take Ibrutinib if they would fail Chlorambucil. Now, I think that the guidelines for that crossover were pretty strict. It had to be reviewed by an outside committee, and it had to meet the strict definition of progressive disease. So it may have delayed that crossover a little bit more than what might be done in community practice. But even so, it's really telling that you have a survival difference between patients treated with these two oral agents. As you know, it's been very difficult to show survival advantages when you compare drugs such as Chlorambucil versus fludarabine. It's very difficult to see a survival benefit. So for us to see a survival benefit after a short follow-up period is actually quite striking.